Hi, everyone. Welcome to this session. Shall I continue? Yes. Okay. Hi, everyone. I'm Kate Golden. I'm Senior Nutrition Advisor at Concern Worldwide, and I'm joined in this presentation by Erin McCloskey, who's an independent consultant who has also been working with Concern Worldwide for some time. And we're going to present on CMAM Surge, Managing Peaks in Nutrition Caseloads from Within the Health System. That title may be slightly different than what was on the guide, but this is what we're going to talk about. Okay, so I am going to start with CMAM Surge. What is it? It's essentially an 8-step process that has been designed to support health systems and empower health workers to better anticipate, prepare for, and manage fluctuations in the demand for wasting treatment. Some of you may be aware that there's been a shift in terminology to talk more about wasting rather than acute malnutrition, but we've stuck with the term CMAM Surge because it's just caught on. And the approach is explained in this global CMAM Surge approach, the operational guide, and a set of tools that comes with it. And it's been designed for, and it adds the most value in context where predictable peaks in wasting occur due to, for example, a lean season, malaria high season, seasonal migration or workload, etc. So we're really looking at predictable peaks during particular months of the year where we know acute malnutrition is going to go up and potentially overwhelm a health facility or a whole health district. So on to where did it come from? It was first piloted in 2012 in Kenya by Concern and the Marsabit County Health Department. And it came about to address weaknesses in the traditional response to nutritional emergencies that Concern and others observed. And these weaknesses included a late response, often waiting for nutrition survey results before evidence of an emergency had been agreed. And they were often NGO or UN led. The responses were often parallel to the health system, very short term, often 6 months maximum. They weren't tailored to local capacity. And because of all these factors, they tended not to be very cost efficient. And there was a pivotal article that resonated with a lot of nutrition practitioners in the Field Exchange in 2010 by Peter Haley and Daniel Tawal-Dabera, which suggested a new design framework for CMAM programming. This article didn't exactly lay out CMAM Surge, but it definitely triggered a lot of thought around how we needed to reorganize ourselves and led to the question, the pertinent question was really, how can the response be so inefficient when these emergencies are often so predictable? So at the moment, CMAM Surge is being implemented in 9 countries, 2 were planned and 3 were implemented and for various reasons have not continued, probably due to funding. And there's a map, you can see it started in Kenya, continued with Concern, we piloted it in Niger and Ethiopia, and then it really took off from 2016 onwards in the Sahel and West Africa. And over the next 18 months, Concern plans to initiate pilots of the approach in Sudan and DRC. And as I said, there are 8 steps, and these are to be completed for each health facility in a health district, led by the district team, but often it may be that district team may be supported by an NGO to facilitate the process. And there are 3 phases of these 8 steps. There's a setup, there's monitoring and action, and then there's a reflection period. I'm going to illustrate some of these steps in the following slides, but just to give you an overview, the first step is trend and situation analysis, followed by a review of the capacity in a given health facility, and then a setting of thresholds, which are based on monthly admissions of wasted children. And then and these thresholds are really meant to represent a level above which the health facility will start to not be able to manage the services that it needs to deliver. That they need to deliver. The fourth step is about defining and costing surge actions. So actions that the health facility themselves can take once their capacity starts to be overstretched because the admissions have gone above an established threshold. Or additional support when they go above higher thresholds that would come from the district, for example, an additional staff or an additional vehicle or some support to get RUTF or other medicines to the health facility. And then step 5 is formalizing those commitments between the health facility and the district health team. And then once it's set up, we move into monitoring those caseloads, the monthly admissions, wasted children coming for treatment at the health facility against the thresholds that have been set up. And then anytime those thresholds are crossed, support or actions will be taken. So you scale up support. And then when they go back down to normal, that support is scaled down. And then there's a reflection period to consider what went well, what didn't go so well in the surge response, and particularly looking at the thresholds and seeing were they set at the right level and what needs to be changed before the next surge. So the step 1, as I said, trend analysis, which really entails, and these are kind of standardized wall charts that are used. The seasonal calendar is used it's like any other seasonal calendar to help the health facility team and community members predict when acute malnutrition cases or sick children, cases of malnutrition or sick children will increase. This is a wall chart from Tawa in Niger, where Concern has been rolling out the approach. And then we have historical trends analysis, looking at cases of severe wasting. In some cases, if the health facility is delivering services for moderate wasting, we'll look at those, malaria, diarrhea, pneumonia, and looking again where they peak, which months, and where they particularly overlap and would put pressure on the health facility. Then we have the capacity assessment, which is really looking at what is a normal workload for this health facility. And then the thresholds are set. So this is from Gosbeda in Chad, and this would be a historical trend of wasting cases, malaria cases. And then the health team, directed by the district health management team, would set an alert, a threshold, so number of cases admitted per month. That would signal an alert, a serious situation, or an emergency. And those thresholds are agreed and, as I said, formalized in commitments, as are the actions, those post-its there. This is step 4. Those post-its there represent actions, surge actions that can be taken by the health facility or that require kind of up here at the emergency level support from the health district. And then step 6 is monitoring those cases monthly to see against those thresholds. You can see the dotted lines there are the thresholds. So far, CMAM learning, we've had 2 evaluations, 2 more formal evaluations. There have been a number of learning events at regional level and at global level, country level, many visits and documentation exercises. And some of the things that have emerged, these are just a few of them, and there's actually a series of articles summarizing some of the learning and the way forward on CMAM Surge in the Field Exchange. It's just out, so I can share that link with this group. But one of the first things that we have seen across the board is that the approach has been highly acceptable to health workers, and they have found it very empowering. And we think this is because it really focuses on helping them manage their own workload, so giving them the tools to anticipate and manage when those caseloads are going to go up and how they can seek support. It's also improved health facility staff use of data for decision making and, as I said, planning. And it has the potential to predict nutritional emergencies early. And we've seen this in Kenya. Kenya is probably the strongest example of government scale up of the approach. It's across all of the arid and semi-arid lands of Kenya. And it is able to predict nutritional emergencies when the cases start to go up, but also to do so relative to the capacity of the health system to respond, which is an improvement on some of the other early warning systems that we've seen. It also has the potential to be applied to seasonal child illnesses, so malaria and diarrhea alongside acute malnutrition. And some experience has already emerged from this, particularly in West Africa. So moving forward, as I said, scale up is really taking off. Kenya is very advanced. West Africa and Sahel is moving quite quickly. There's an evaluation planned in Pakistan. I think I forgot to mention Pakistan on that map, but that's the only Asian country where Surge has been piloted. And then Concern is planning to pilot in Sudan and DRC. We also plan to pilot the health surge approach, so a more holistic approach looking at malaria and diarrhea, applying the same principles as CMAM Surge to these illnesses. We have adapted the existing tools for CMAM Surge for these other illnesses, and we're planning to pilot this in 2 countries, Niger and Kenya, and possibly in Mali as well with Save the Children. We continue to document and learn, revise, and all of this learning will then culminate in a revision to the global toolkit by the end of 2021. And there's a CMAM Surge Global Technical Working Group, which is overseeing this, and there's also a strong West African CMAM Surge task force coordinating activities and learning in that region. So finally, because Erin and I know that we are amongst health practitioners who really know health systems well, and we are admittedly nutritionists who've been working with services for wasting for a long time. But what we would love to hear from you is if you, and I know it's time for your questions, but as you're thinking of your own questions, maybe you could reflect on whether you see an added value of this approach for health systems, and if you can see a place for it, an added value within broader health system strengthening initiatives. And are there other health system strengthening initiatives looking at seasonality and work planning based on historical caseload analysis? We would love to hear your thoughts. And I think there's a poll that should go out now. I'll just thank you on behalf of Erin and me, and we are here to answer any questions. Thank you.
So that poll should have popped up on your screen. And I think if you have any questions, you can drop them in the chat box.
So do you see the value of health surge? Yes, or yes, it can add some value, but currently duplicates. This is what we are discussing a lot with our health colleagues, is where is that special niche for this approach? Or no, you don't see that it adds any value. Happy for your honest responses. I can't see the chat, so I hope that.
I can see the chat, but currently
nothing. Okay.
Yeah, we really love to know if you feel there is a duplication, because we do not want to duplicate. So if there is an approach that's looking at, as Kate said, at historical trends, particularly contrasting admission trends with the capacity of a facility to respond to those trends, we'd really love to hear about it.
And if we don't have an opportunity now, we'd love to hear, if you're interested in the approach, we can organize more discussions. I think there's even a suggestion that there may be another core group presentation around CMAM and health surge, and plenty of other opportunities.
There's a great question, Kate, about identifying priority areas for COVID immunization. Could it help with that?
Ooh. Do you want to take that one, Erin, or do you want me to?
I think, yeah, I'm not sure. I think we'd have to reflect on that. What we realized with COVID is that it's not an approach that works for diseases that are notifiable to a very small degree. So that could be COVID, that could be Ebola, because those systems sort of have, they have disease response actions already in place. So it's more about those diseases that we see seasonally but are notifiable to higher degrees or have uncertain thresholds. But in terms of identifying areas where we see vulnerability, it could be good for that. There's another one, Kate. The case threshold that leads to categorization is interesting and likely an important indicator to better prepare for HSS work. So more of a comment than a question. Yeah, we agreed. There's just a comment that says pneumonia surge. So maybe that's, is pneumonia.
Yeah, I think when we're looking at health surge, we're really looking at what are the illnesses, as particularly amongst children, that are driving up the workload for health facilities, health facility teams at certain points in time, certain months of the year. So if pneumonia, acute respiratory infection is what is driving up caseloads and making it difficult to deliver quality services at certain times of the year, then definitely. And that decision about which illnesses are appropriate would really first you'd look at the district, and then you could really look down as low as the health facility, because I know in some countries, Ethiopia for example, in the same district, same warda, you'd have huge differences. In lowlands you'd have malaria, and another health facility it might be pneumonia, as you say.
So Kate, I don't know if you can see the poll results. Very positive for yes.
Okay, yes.
For those of you who have said that it duplicates, which is about 20%, we'd love to hear, we really honestly would like to hear where you think it duplicates so that we can make sure that we're not duplicating. So if you want to just drop it in the chat box, or if it's something that you want to take offline and contact us later about, that's fine as well. But if you want to drop it in the chat box, that would be great too. So,
oh, there's another chat. I see.
Okay.
Have you seen the chat? The question?
So the one from Sierra Leone?
Yes.
Yes.
Do you want to answer that, Kate?
So in Sierra Leone, this is from Megan Christensen. In Sierra Leone, when we piloted this for malaria, although I haven't followed for some time now, initially we struggled with the district response and ensuring adequate funding for the surge responses. Is this something you're seeing in other country contexts? I think it is. I think it's a challenge, and it's why the supporting NGO might still be there behind the district at the moment. But we are really working to link the district into larger, maybe national level contingency funds where they could access that. And that does require some more linking and understanding and analysis of those systems. But I think at least it's a step forward, instead of the NGO directly providing everything up front, that at least the requests and the agreement about what the surge actions are ahead of time are agreed between the health facility and the district management team. And then if the district management team for now needs additional support, they can lean on an NGO or another source of funding. In Uganda, there is tracking of malaria outbreaks with accompanying surge response. Great. Is that part of a traditional malaria disease surveillance and response, I wonder, or is it surge? Because I think a key distinction that we've been trying to make to clarify this duplication is we don't want to duplicate at all an outbreak response mechanism or a disease surveillance and response mechanism. What we're really focused on is helping health facilities manage the caseload that they face during certain months of the year. So all of that disease surveillance and response should happen, outbreak response triggering, as Erin said, according to certain national thresholds. But we are really focused on the health facility and helping those health workers just get through the tough months. I feel like I may have missed a couple of questions above. I'm just going to have a look. A big fan.
There's a great question from Megan. There's a great question from Megan about community members' involvement in the surge process. And this is a really good question. I think there is going to be sort of a pilot looking at how we can, Kate, correct me if I'm wrong, how to design and work with the community on a sort of community type surge using data, using that historical data to plan actions at the community level. Is that right?
Yes, in Kenya under USAID funded Nawiri project, that is the plan in Marsabit. So there's definitely a move, and I think Erin, who has evaluated several of our CMAM Surge programs, I think you've found as well that CMAM Surge itself is really strengthening that link with community, and then our Kenya team is going to take it a step further and see how can you use the same data and the same principles to actually prevent some of the spikes before they happen, rather than waiting until they arrive at the health facility and letting the health worker treat them.
So I think that
okay, I suppose that this is a segue to the second presentation. I think it's Kate now. Kate, can you go to the next slide? It's on ICCM implementation in fragile settings. Next slide. So if the team will present, I'll just give the introductions, and then Kate, Nefra, and with support from Jim, we will continue the presentation. Next slide. So a little bit about fragile settings. We all have an understanding and a grasp of what it means, but just to be clear, those are the areas where disproportionately we find more child deaths or even maternal deaths than on the average. It can be a country that's fragile, it can be a state in the country, it can be a region, it can be a smaller or a bigger setting. So there is, in general, fragility, and the communities and the health system are vulnerable to shocks, stresses, and coping with them because, and mostly, of course, not in every area, government systems are weak and they have problems managing those shocks or absorb them. Also at the population level, there is sometimes grievance with the authorities or distrust, and resources are unpredictable, especially search resources, for example, would not be there. And causes of mortality when it comes down to child health are mostly infectious diseases, pneumonia, diarrhea, malaria, for malaria, if it's in an endemic area. Next slide. So ICCM is one of those strategies to address those infectious diseases and other childhood illnesses. It's an important strategy to assure equity, because it's targeted in the hard to reach, end of the road communities, and introduces those life-saving preventive and curative care at the community level, implemented by community health workers. Of course, in fragile settings, the support from the government is sometimes a challenge. And when we talk about investment and bottlenecks, especially in those settings, they're an extra challenge. So scaling up has been feasible and has been done in many countries, but it's still not clear how successful it was in fragile settings. So now Kate will tell us what we did in the DRC. Kate, over to you.
Kate, you're on mute.
You're on mute, Kate.
Thank you. I'm sorry, I've got too many screens going with sharing. Can you hear me now?
Yes.
Perfect. So I'm just going to talk for a minute or two about the actual scaling up. And so what you'll see are there are different frameworks for scaling up. The one on the left is one we used for a study I'll talk about in a minute in DRC, and it's just an adaptation of the ExpandNet conceptual framework along with the consolidated framework for implementation research, and just shows, you know, kind of some steps in the process, as well as the one on the right-hand side that shows just kind of the waves or camel humps of how achieving scale. And then we want to talk about the ExpandNet definition of scaling up is deliberate efforts to increase the impact of innovation successfully tested in pilot or experimental projects so as to benefit more people and to foster policy and program development on a long lasting basis. And so really that's a lot of words, but it's really about expanding effective coverage, so quality and services for more people, and institutionalization that is really, you know, getting the policies and the guidelines and things like that so it's more sustainable and can kind of function on its own. And so we did, we're going to present quickly on a case study from DRC. And on the left-hand side, you'll see there were don't need to read the details, but DRC did a pilot of ICCM in 2005 and made a decision to scale up ICCM in 2007. And just, you know, there were some changes and many expansions along the way in DRC until 2018, 2019, when we completed this study. And the map on the right just shows that at the end of, in 2017, 2018, there are over 7,000 ICCM sites in DRC. And so we did some of this quantitative mapping, but also qualitative, and found that there were positive drivers of scale up in DRC, that it was community owned, supported by the government and stakeholders with policies and implementation guidance, so that institutionalization piece. And everyone felt it was a good intervention to meet the needs of DRC, you know, where there's more rural or remote folks and high under 5 mortality. But there was as Michelle mentioned, in fragile settings, there was this reliance on unpredictable resources from external sources who had their own mandates, such as the Global Fund for malaria. There were supply chain issues and sustainability and lack of motivation amongst a cadre of, not lack of motivation, but the cadre of community health workers in DRC is not paid. And then just the overall health system in some places in DRC isn't strong, so it's harder to put that community site below the health system that has some of these same struggles. I'm gonna go to the next slide and turn it over to Nefra, who took a look at some of the quantitative data.
Thanks, Kate. So to complement the qualitative review that Kate just spoke to, we also undertook a secondary analysis of data from MICS and DHS surveys conducted in the DRC between 2001 and 2017-18 on sources of care seeking outside the home for sick children under 5. And here's a snapshot of some of this analysis showing patterns in care seeking for sick children under 5 with fever as a proxy for malaria over time. And the blue bar here illustrates whether a child's mother recalled seeking care from any source outside the home when her child had a fever. And the red bar here shows whether she recalled taking her sick child to a community-based source of care, which we used as a proxy for ICCM care seeking. So this included things like mobile clinics or nurses, community health workers, or village health agents as coded in the surveys. It didn't include sources like traditional healers, friends, or family, for example. And we chose to present this snapshot for fever, given tremendous donor investments in malaria in the DRC in recent years. And as Kate's noted, this has included the likes of the Global Fund, the US President's Malaria Initiative, World Bank, Global Financing Facility, and others. Despite these investments, you'll see that only 2 to 4% of mothers sampled reported taking their febrile children to a community health worker or for ICCM between 2017 and 2018, or 2001 rather. These data also suggest no increase in ICCM care seeking for fever in the DRC over the past decade or so. And we found similar patterns in care seeking for diarrhea and for acute respiratory infection, or ARI. And this is national level data, but we found similar patterns in the regional data. In the latest MICS, for example, we found that in Kinshasa, the capital, and the Kasais were the only regions with just over 5% of ICCM care seeking for fever, But then in contrast, we looked at a region like North Kivu, which has faced persistent conflict and humanitarian assistance for many years, and where we hence might have expected community-based health services like ICCM to be especially important. But there we were surprised by data suggesting that less than 1% of children under 5 with fever receive care via ICCM. Now, certainly there's a lot to unpack in this data and in the survey designs, but we found it provocative all the same. Next slide, please. So building on that, these pie charts show the proportion of care seeking via ICCM as a proportion of any care seeking outside the home for children under 5 with fever over time in the DRC. And among the mothers who sought care outside the home, you'll see that only about 6% at most recalled seeking care through ICCM. And what's more, this proportion doesn't seem to have increased overall over roughly a decade. These proportions also seem low, given that an estimated 60% of the DRC's population lives in rural areas. That said, we don't really know how many children live within 5 kilometers of a health facility and are thus eligible for ICCM. And this really presents challenges to understanding what the so-called target threshold level of ICCM care seeking might be in the DRC. Next slide, please. So we've just offered a few reflections on ICCM scale-up experiences in the DRC, but we'd really like to hear about your perspectives and experiences supporting ICCM scale-up efforts in fragile settings. We have a couple of discussion questions here to guide us, and our starting point is really this: recognizing the critical importance of community-based primary health care for children in fragile settings, does it always make sense to support the scale-up of ICCM in these settings? And really, what context and conditions in fragile settings favor supporting ICCM scale-up from your perspectives? Or what factors are red flags for the scale-up of ICCM in fragile settings? So we are actually going to toggle now to a Rise Up board, for which we'll share a link in the chat here.
Nefra, I think it's going to be easier to go to the next one and then toggle to the, since I'm sharing both.
Okay,
Maybe
sure.
we lay out all 4 questions and then do the Rise Up board?
Sure, absolutely. So this is the second set of questions. The second set of questions here for you all to consider is, to ensure that children in fragile settings have access to life-saving care, should we perhaps reimagine ICCM scale-up models in these settings? And maybe that's in terms of inputs or processes or structures. If so, how? But then maybe on the other hand, do you think that we should be considering alternatives to ICCM scale-up for treating sick children in fragile settings? Maybe, for example, that might involve investments in more professionalized cadres of health workers for community-based care of sick children. And if so, what kinds of solutions might you propose? And we're really interested to hear about any specific country examples or experiences for scenario A or scenario B here that might come to mind. So we've just thrown a lot at you here, but we're interested to hear your thoughts.
Yeah, and so Nefra, do you want to do the Rise Up pad and put it in the chat?
I think maybe for the sake of time, we'll ask people to share their thoughts directly in the chat window so that people don't have to toggle back and forth between platforms. Or if you prefer to come off mute, please feel free to do so. Another way of thinking about some of these questions, please go ahead.
Well, I was going to just encourage the participants to drop in questions or comments.
Thank you. And thank you, Dennis. Yes, absolutely. Adequate supplies and drugs could be a challenge for sure.
Hi, Nefra. This is Smitha. Thank you so much, both of you, for, because I missed Michelle, a lovely presentation. I think one of the challenges has been, if you have a formal cadre of community health workers, it's still challenging in outreach to the geographic catchment that's being covered is still vast. And so there's not always the ability for those CHWs to obviously, unless they're based at some kind of structure to be for patients to have access. So I think, you know, this it's not always an official cadre, but the community health volunteer, or you know, even like a not a professional health cadre, to help provide not only the preventive and promotive services, but really supporting identification of any danger signs or potential illness that could prompt family members to really seek care. So, you know, there are many reasons why people don't seek care. I mean, security issues, travel issues, transport issues, opportunity costs, lack of belief, etc., unawareness, you know, lack of awareness of signs and symptoms. But I think that's one thing that might help us. And with regards to I don't have any alternatives, but I think when you were talking about the red flags, just going back to the person who talked about adequate supplies and drugs, I also think the quality of those supplies and drugs, especially where there's not a strong regulatory system or it's been broken down because of, you know, for a variety of reasons, becomes really critical. So even if the program is strengthened, the effectiveness of the interventions don't yield the results we want over.
Thanks so much, Smitha. And similarly, I noted on Kelly's comment or question here, didn't you mention compensation for informal ICCM workers being an issue? Potential compensation is an issue, or time commitment. And that's certainly the case not only in fragile settings, but in all settings where ICCM has been supported. And I guess our question here is really, are there any critical requirements for ICCM scale-up that are unique to fragile settings and that maybe aren't being adequately accounted for by and large during scale-up processes? So this is when we consider some of the unique characteristics of fragile settings that Michelle spoke to at the beginning, like low capacity of government systems, high levels of underlying grievances among the community, extreme vulnerability to routine shocks and stresses. Megan has made similar comments about challenges to motivation of community health workers, particularly if they're not remunerated. And thanks to Katie for sharing the guidelines supported by SAVE for implementing ICCM in humanitarian settings. So Katie, would you like to come off mute briefly and speak to your comment here about opportunities to evaluate and field test the guidelines for implementing ICCM in humanitarian settings? What has been the experiences to date, and where is there more work needed perhaps?
Unfortunately, I am no longer at Save the Children, so I haven't heard kind of the progress that they've been making in terms of seeking opportunities to field test this. But I did help with these guidelines when we were developing them. And at the time, we were hopeful for opportunities to test them in similar ways that the newborn field guide in humanitarian settings was being tested in South Sudan and Somalia. And so I'm not sure if there are people from Save the Children who can comment on any progress made in this area, but I do think that these guidelines are a helpful starting point and are based on Save the Children's experience in these fragile settings with implementing CCM programs.
Thanks for that. I appreciate that, especially having put you on the spot. And thanks to Smitha as well, certainly for noting the considerations that are especially germane to fragile settings around security issues and the movement of people, which can really make it difficult to track and follow up children. Dennis, would you like to perhaps come off mute to speak a little bit more to the South Sudan experience that you've cited in the chat here?
Yeah, sure, no problem. Very briefly, this was during my time at World Vision. As part of the US government's Child Survival Health Grants program, we introduced integrated, actually newborn child health intervention in South Sudan. And obviously, the key intervention was equipping and training home health providers, which is obviously community health workers, to identify and treat as well as refer. It's an interesting experience because they never even knew how to hold a pencil, but our first task was to help them hold a pencil, how to write, and then eventually go into these kinds of clinical management, which was great. But in the process, we also came up with identifying few people. I think we identified about 4 or 5 people from their own village who had the potential skills or education, who could be trained as nurses. I believe we worked with AMROF at that time, and then reinstated back into the villages, so that, you know, the whole idea being that there are potential people in their own communities who has the skills or interest but doesn't have the resources to be trained, but if given an opportunity they could be reinstated back in their villages, is another model potentially. Obviously there are numerous bottlenecks there as well, but I think it could be a promising practice.
Thanks, Dennis, for sharing those experiences. And if there's any documentation from the South Sudan experiences that you might like to share in the chat, we'd really encourage you to do so. Thanks for that. We are almost out of time, but I did want to acknowledge the comments around the need for sustainable financing, really bringing us full circle from the comments that Michelle started with around the unsustainable and sporadic financing that we often see in fragile settings. And as we look ahead to the Institutionalizing Community Health Conference, or ICHC 2.0, I think it's notable that really what a lot of countries are looking to see as an outcome from that conference is resources and assistance to support more sustainable financing of community health platforms and services, including but not limited to ICCM. And we are just about out of time, and I'm afraid then it's time to wrap up. Thank you all for your participation and critical insights today. I wish we had more time, but hope that you will help continue and deepen the debate through engagement in the Global Child Health Task Force and its subgroups. Membership in the task force and its subgroups is open to all, and you can sign up through the link that Kate provided on the screen just a moment ago, and that will drop in the chat window as well. Thanks again to all.
OK, merci beaucoup. Omar, est-ce que tu peux partager ton écran? OK, merci beaucoup. Donc, bonjour à tous. Moi, c'est Megan Pollock. Je suis un conseiller avec are functioning so well is because of the social support factor of them, that women feel comfortable getting together, and also that we have a lot of community leader support for these groups, even in fragile settings. OK, donc vraiment merci à tous. Ça, c'est la fin de notre session. Si vous avez les autres idées, les autres réflexions, Omar et moi sont toujours disponibles, et je sais que Alliance a notre contact. Donc, merci beaucoup.
Thank you, everyone, for attending this session. And I hope you have learned a lot. I'm sure you have learned a lot from all the presentations you have heard in this room. I want to encourage you, first of all, to join others in the closing ceremony, in the closing plenary, and in the hours giving. And secondly, I want to encourage you guys to visit the exhibition place and the posters, and join the others in the network space to network and to have discussions. And I want to thank our speakers very much for what they have done today, all the wisdom they have shared, and especially the core group for arranging this for us. I want to thank also our technical helper, Hilary, for helping us through. So let's go on to the plenary session. Au revoir, bye, see you.